I continued to accumulate people who were HIV infected, and this is not something that I was taught about at medical school, so I had to self-learn everything. I wound up closing my office on Monday afternoons and foregoing any kind of income from there, and I would go to Miami Valley Hospital in Dayton, and I would volunteer my time and work in the infectious disease clinic and help people who were seen for this new disease process called HIV. The more I did that, the more pissed off and frustrated I got because patients were being seen, but they were not being treated in a holistic manner. They were being treated only for their HIV-related symptoms. So a person would come in and they would have like upper respiratory infection, they would have cold symptoms, runny nose, sore throat, just that. And the infectious disease doctor would say, well, this is just a cold, go back to your primary care doctor, they'll take care of it. And the people would just sit there and cry because they said, I've been there, I've done that. Anything that's wrong with me, my doctor thinks is HIV related, and they don't know what to do. They're scared of it. They don't know how to treat me. No one touches me. I'm actually afraid of going back there because I'm not welcome there. And so that's when I said, this has got to be changed. The treatment of people needs to be changed.
Dr. Robert Brandt, Dayton, Ohio. Hi, my name is Nick Wood, and you're listening to How to Invent a Virus, an exploration of HIV/AIDS communication in America told through the 5 W's of journalism: who, what, where, when, and why. In our last episode, we covered who is HIV by speaking about some of the groups most impacted by HIV and the benefits of incorporating their voices into conversations about addressing the virus on a systemic level. We touched on how that was achieved on a governmental level through advocacy at the intersection of politics, science, and sociology. But systemic change requires efforts from all fronts. In this episode, we will specifically be exploring how the media has been used to educate people about HIV and how that media education shaped and continues to shape how people answer the question, what is HIV? Okay, so the question, what is HIV, could have a lot of different answers depending on who you ask. And this is because of factors like stigma and people's own proximity to the virus that kind of cloud their judgment and how they receive information about HIV. So before we get too deep into this episode, I want to take a minute to simply and objectively answer the question, what is HIV, at least from the basics of a medical standpoint. In the last episode, we touched on the ways in which HIV can be transmitted through bodily fluids like blood, semen, rectal fluids, vaginal fluids passed through anal or vaginal sex, or through sharing injectable drug equipment. It can also be passed from mother to child during labor, childbirth, or through breastfeeding. All of these factors tie into the social elements of the virus, as it's transmitted through a human exchange and often through means that are risky and highly stigmatized, such as unprotected sex, queer sex, and injection drug use. But of course, there's more to HIV than what is seen on the surface social level. HIV, human immunodeficiency virus, is unique in that the virus doesn't necessarily have any consistent, recognizable surface-level symptoms. So when HIV first enters your body, you may not initially notice symptoms any greater than some flu-like symptoms that might eventually go away without treatment. What HIV does instead is target cells in your immune system, known as helper T cells or CD4 cells, which fight off other diseases. Then, if untreated, over time your immune system becomes weakened and severely depressed, leading to AIDS, acquired immunodeficiency syndrome. At this point, your body is vulnerable to uncommon, opportunistic infections, which become deadly because of the amount of damage done to your immune system. Common opportunistic infections include pneumonia, salmonella infection, and tuberculosis. but nowadays it's less common for HIV to progress into AIDS because of advancements in treatments that can suppress one's viral load, sometimes to the point of being undetectable, and allow your immune system to operate effectively. Further, an undetectable viral load also means that the HIV in your body cannot be transmitted. Of course, there are many ways to prevent contracting HIV, such as PrEP or pre-exposure prophylaxis, using a condom and having protected sex, and using clean needles and syringes when engaging in injection drug use. It can also be beneficial to get tested regularly as well, especially when regularly engaging in risky behaviors. Okay, so in a nutshell, that's essentially what HIV is. But if you were to look back at some early conversations or media portrayals about what HIV is, you might also hear it be called things like dirty, or a gay plague, or on the more extreme side, God's punishment for engaging in immoral behavior. I say extreme, but according to a poll conducted by the Pew Research Center in 1987, that last title was apparently what 43% of Americans saw HIV as. And these different names, different versions of what HIV is, can be attributed to several things, like transphobia, racism, homophobia, classism, or any other number of stigmatized beliefs surrounding the populations most affected by the virus. But these beliefs don't just come from nowhere. Often they stem from a lack of awareness or a limited education on the virus, so to address these false and harmful perceptions, more people need to be educated, and the best way to do that on a wide scale is through the media. Just like creating public policy regarding wide-scale approaches to HIV requires input from the voices of the populations most impacted by the virus, as we discussed with Dr. Arbach in the last episode, so does the creation of effective public health campaigns in the media. Otherwise, your campaign won't be internalized by those you're trying to reach. And this is something that Dr. Marlise Durr noticed while doing research for her article entitled Sex, Drugs, and HIV, Sisters of the Laundromat. Dr. Durr is a professor of sociology and anthropology at Wright State University who specializes in race and labor markets, African Americans and social networks, entrepreneurship in inner city neighborhoods, and stressful life events in African American women. I got the chance to speak with her a little bit about the work she's done. Here's a clip from our interview where she speaks a little bit about her research process and findings.
In 2005, I was at NDRI, which is an institute which studies drugs. And my focus was on dealing with women in New York City, particularly in Brooklyn. So how I would meet them is I lived in that neighborhood and I would go to the laundromat around the corner. And over time, as I got to know the women, I found out who was what they called radioactive and who wasn't. I also learned who had a substance abuse problem and also HIV positive. And many of the women that I talked to and interviewed when I was in New York City and Brooklyn were substance abusers, which also led to multiple kinds of problems. For example, the substance abuse that they were part of usually led to prostitution, had just to survive the ordeal of getting money to take care of a habit. Some of them were employed, a lot of them were almost always looking for jobs. And there was this fear that if anybody found out they were HIV positive, if they worked in restaurants, places like that, they would lose their job. In some ways, they cared about others, but just the need to take care of their habit, they continued prostitution. I mean, they figured if the drugs didn't get them, the HIV was going to kill them. So for many of them, it was a death spiral. And why not continue to shoot drugs if they knew they were going to die from HIV? And what was surprising is in New York City at that time, everywhere you looked, there was information on HIV and, how to prevent it. There were programs, but substance abuse was the thing that kept them moving, if you will. And it wasn't just Black women, it was Black, white, Latino, Asian, all women across all racial and ethnic categories who had a substance abuse problem. So despite the news campaigns, this, that, it was still there with them. But nobody wants to see it that way. Nobody wants to talk about it.
The mass media can be an incredibly powerful tool for educating a wide audience, especially in times of crisis. In our society, the media is our main storyteller. It filters our world and shapes both what we learn and how we learn it. That's why it's so important that the stories and information they put out are accurate and informative. And again, on top of that, it helps to know how the communities you're trying to reach take in and apply the information they receive, so they can go beyond just knowing about something to also knowing how to turn their knowledge into action. This is a principle that guides Tina Hoff and her approach to sending health messages about HIV into the media. Tina is a senior vice president at the Kaiser Family Foundation and the executive director of their social media impact program. KFF is a nonprofit organization that serves as a nonpartisan source of facts, analysis, and journalism for policymakers, the media, the health policy community, and the public. And while at KFF, Tina has been the award-winning creator of multiple pro-social public health campaigns for Viacom, MTV, BET, CBS, and Fox, among others. And more recently, she's been the creator of the Greater Than AIDS Public Information Initiative, which delivers life-saving information and confronts the stigma of HIV in the US. I sat down with her to discuss her experiences creating such large-scale campaigns to find out more about the ways in which the media can be used to effectively educate at-risk communities about HIV. Well, I guess first of all, I want to ask you a little bit about how you initially got involved with HIV and AIDS advocacy and prevention.
So I come at this from a communications background. I was working in public affairs in DC in the 90s, and HIV was like COVID today was really a very, it was a very present health issue. And when I came to KFF, as originally our communications director, we were one of the only foundations to have a dedicated HIV program at the time. And we started recognizing that there was a need to reach individuals with quality information. And we early on realized that sort of a traditional, what was at the time a more traditional public service approach, which was kind of, you make these sort of TV PSAs that go out and were aired in the middle of the night, wasn't really doing it. And we started this model of working in partnership with the media companies that I mentioned, who were at the time reaching the audiences we wanted to reach. And so we thought, let's go where our audiences go and build out messaging that works with company media partners that know how to communicate to these audiences. And we know the public health and the messaging, and we'll work together. And we did that for a lot of years. And it gave us, I think a really great way to kind of learn and think differently about how you approach public health communication that wasn't from, in this very kind of staid sort of separate, kind of way. It's not just about the facts, it's about the human connection and how do you break through shame and stigma and things that were holding people back from accepting or hearing what was available and how things were moving forward. And we've been able to bring in our model and style of communications and kind of a different way of, doing this than the typical public health department approach, to doing partnerships with health departments in these regions that can get the messaging out through, with our working with us, and we can do a better and more efficient use of limited public health dollars that way by providing them with quality messaging and creative and letting them put their dollars into distribution and really focused placements.
I was looking through some of the work that you've done. There was this article about what we can learn from HIV and how we are talking about COVID. Some of the things you mentioned being maintaining urgency while also conveying hope, acknowledging the impact without furthering stigma, and not messaging in a vacuum. And it just seems like a really complex balance that you have to be aware of whenever you talk about HIV and other viruses.
Yeah, absolutely. I mean, and as somebody also who, I come at this from a communications background and interests, it's an incredibly complex, but also really interesting area to talk about, because you are trying to balance, issues around both messaging to individuals about why you want to, take all the precautions you can to try and avoid contracting HIV, but at the same time, we have more than 1 million people living with HIV in this country. Even with the best of responses, we know that viruses continue to spread.
Yeah, and it's sort of like a push and pull too, where like we have made so many advancements in like treatment with HIV, and with COVID we have the vaccines now, and so it feels like we get to these places where people are like you said, there's over 1 million people living with HIV, but people still act like, well, it's a livable condition, so like why should we worry about it?
HIV, in a way that's very different from COVID, given where we are this many years into the HIV epidemic, is that it's something that you see very segmented in different populations and geography areas. So when when we would survey Americans about, how do you think about HIV, or how worried are you about it, or is it a big concern today? The statistics that you see across the country are, HIV isn't really even still a problem. I don't think about it. Don't we have all of these? Haven't we basically figured this out? But if you go into certain communities or geographic areas, particularly given the disproportionate impact that we continue to see with HIV in Black and Latinx populations, it's a very different conversation. There's a much higher familiarity with how it can impact lives. You have stories even today about losing family members to HIV, despite how far we've come with the advances in science. You hear about, again, the sort of stigma of talking about it is very present, and it's a very deep concern. So I don't know that it's so much that people are saying, oh, it's not that big of a deal if I get it. There's, very different worlds that people are living in around it that you'll still hear even here. But there's also a matter, particularly in the communities where HIV remains a serious threat, when you look at Black, Latinx, the intersect with LGBTQ. It's communities where there's so many stressors and pressures. There is a desire to just push it out of mind, but I understand too, where it's not something. You feel like there's a lot of struggles and issues that are already kind of in play, and this is one more. And so there is it's human nature to think that you'll be the person exempt, or it won't be you. People just don't think that way. And it's hard to get them to, think about something that might happen and to take those actions, like in the case of PrEP, taking some kind of a medication every day to prevent something. You'd rather hope it never happens to you. And so I think that's more of the, attitudes that we hear, less of the, I don't really care if it happens. I think there's still tremendous anxiety around it, and, legitimate concerns about impact on health and long-term health.
On that note, in that article, again, it mentions acknowledging that disproportionate impact without furthering the stigma. And so I guess I just want to know a little bit about how you make that approach, educating those who need it most without making it totally just this is only your issue and no one else has to think about it. Right.
And it's, it's absolutely another, element that adds to the complexity of messaging about this. So when we launched Greater Than AIDS, we originally were launching it very specifically to focus on the Black community, based on the statistics with HIV, the just tremendous disproportionate impact in that population. And we're very adamant in the beginning about only Black faces, only Black stories. And we did that, and we started hearing from people, yes, they want to hear from people who look like them and who live lives that reflect lives that they've had and come from communities they come from, but also wanted to see a diversity of faces and others who were affected. And that is also part of, showing a collective response and impact, and kind of addressing that other issue of that you just mentioned, of not further stigmatizing or isolating a community because of this impact. And we also, we try to be focused on empowerment, on strategies to move forward, but we also don't shy away from the truth. It's hard. It's devastating to get a diagnosis like this, especially, when in many cases the people we're talking to are dealing with an array of other issues at the same time. And I think it's important to, we've always found it's important to acknowledge and recognize that and help meet people there, and then show people who had faced a struggle and how they moved forward, and that it's, can be a process, but that there are paths forward. And then also trying to really highlight that there are places and people that you can go to who can make that change for you. And more often than not, for people who find that path forward, it's because they've made that connection. And so we try and provide that connection through the stories we put out and connecting to the programs that can then, meet people in real life to help them go forward and to know what options even are available to them.
The question, what is HIV, seems so simple, right? It's just a virus that attacks your immune system, right? I mean, while that may be true, if it was just as simple, and I use that word loosely, as the biomedical definition, then I probably wouldn't be here doing this podcast today. The reality of what HIV is varies from person to person as we carry our own biases, understandings, associations, and even stigmas about HIV that can't be ignored when we're asked to define it. And those ideas can be formed in any number of ways, but for many people, the media is where we go for exposure, whether that's for glimpses into the lives of others or for information to help us navigate the cards we've been dealt. And that's why the story of HIV and the question of what it is so deeply tied to the media, and why that media needs to accurately represent the world we live in and the people who live in it. So there are layers, a lot of layers to HIV, and we're still just scratching the surface. But I think this is a good place to leave off for now. In the next episode, we'll examine where is HIV by looking at populations impacted by HIV and examining some of the complex factors that might put them at greater risk for contracting HIV and inhibit them from receiving adequate care. Once again, I'm Nick Wood with Wright State University, and thanks for listening to this episode of How to Invent a Virus. A special thank you to Dr. Robert Brandt, Dr. Marlise Sturr, and Tina Hoff for speaking with me this episode, and to Dr. Marie Thompson for her advisory support in the creation of this podcast. For more information on HIV resources in your community, such as testing, treatment services, and prevention options, click the link tree in the description of this episode. Thanks!